We're talking today about fluid and electrolyte balance and pH. Um, just some general aspects, okay? Which is that if we don't have proper fluid and electrolyte balance, we create either hypertonic or hypotonic conditions. Okay? In a hypertonic condition, a cell will shrink and lose function. Okay? In a hypotonic condition, the cell will swell and potentially rupture. All right. pH is a critical parameter because at an improper pH, all right, you're going to disturb membrane potential. All right. The same happens with electrolyte imbalance. And that means that the cell can't do any work, including the work of transport, nerve signal transmission, and muscle contraction. All right. So this is why it's critical. In addition, okay, if these values get out of proportion to what's compatible with life, you're going to end up denaturing protein. And if you denature protein, those functions stop and the cell will die. Okay? So this is why it's important. Now, as to why this goes wrong, in instances where the body pH gets too high or too low, or in instances where electrolyte balance is disturbed, generally what's going on is that either your urinary system or your endocrine system is malfunctioning. Okay? It's almost never the result of diet. Okay? So let's take a look at body fluid first. Okay? Total body water includes intracellular fluid and extracellular fluid. So the intracellular fluid would be the fluid that's contained inside the cells and makes up a large portion of the cytoplasm. All right. The extracellular fluid is outside the cell. So that could be intravascular fluid, synovial fluid, cerebrospinal fluid, sweat, urine, pleural, peritoneal, pericardial, and intraocular fluids. Okay. And interstitial fluid, right, which we already noted. There's a free exchange of water between these compartments because it basically follows osmolality, all right? So where the solutes are, the fluids will pursue, all right? That's an inevitable outcome. If we look at children in pediatrics, water makes up between 75 to 80% of your body weight, and you're susceptible to significant changes in body fluid. Dehydration in newborns is a big deal because they have a large surface area to volume ratio. Okay, in the aged, we have a decreased percent of total body water, and so we have decreased free fat mass and decreased muscle mass. We have a decline in renal function and diminished thirst perception. So the renal decline, as with the decline of all the other body systems, is due largely to simply lack of tissue to do the job. As you age, you lose tissue because you lose cells, because the rate of cell death accelerates compared to the rate of cell regeneration. And as a result, tissues thin, organ function declines, and eventually organs shut down. Okay? A lot of this has been linked to the loss of genetic material with every cell division. The less genetic material you have in the nucleus, the less genetic material you have to run the cell. Once we get to critical information, the cell is going to die. All right, it can't maintain itself anymore because it's lost the instructions for the tools of life. Okay, the diminished thirst perception is just the result of a decline in receptor function for the aged. This is one of the reasons you have to remind older people to drink and even eat. Okay, the test that you can use on the floor to determine dehydration is simply to pinch the skin. And if the skin stays tinted, they need water. Okay, they need fluids. The decline in the hunger mechanism means that you have to monitor their food intake. And part of the reason that the hunger mechanism is less effective in the aged is loss of gustatory sensation, loss of olfactory sensation, so that basically your food loses flavor. It doesn't taste like much. And you have fewer cells demanding less energy, all right, because tissues have thinned and organs have reduced in function. And as a result, there's no need for as much food consumption naturally in the aging process. Okay, so these are the challenges you face dealing with geriatric medicine. Okay, water movement between fluid compartments is driven by osmolality and osmotic forces, the presence of aquaporins and Starling forces, right? Net filtration equals the forces favoring filtration minus those that oppose it. Okay, so this takes into account both hydrostatic and osmotic forces. Okay, it's probably worth it to review osmosis, so we'll do that now. So hold on just a second.
Diffusion is the net movement of molecules down a concentration gradient. This process allows small molecules, such as oxygen and carbon dioxide, to cross the plasma membrane. Most polar molecules, such as sugars and proteins, cannot freely cross this lipid membrane. Although water molecules are polar, they are small enough to pass through the membrane freely. This special case of diffusion that involves the movement of water molecules across a membrane is called osmosis. If a molecule, such as urea, is added to one side of a membrane, it will not be able to diffuse across the membrane because it is both large and polar. Because of its polar nature, it will interact with other polar molecules such as the water. This interaction reduces the number of free water molecules on the right-hand side. With fewer free water molecules on the right-hand side, there is now a net movement of water molecules down their concentration gradient to the side with the urea molecules. Because more water molecules are moving into this area than are leaving, the water level on the right side will rise. If the osmotic concentrations of two solutions are equal, the solutions are isotonic. However, when the solutions have unequal osmotic concentrations, the solution with the higher concentration of solutes is hypertonic, and the solution with the lower concentration of solutes is hypotonic.
Follow. Okay. Water movement moves between interstitial spaces, the cytoplasm, the blood, and the fluid that we secrete, the urine and the sweat and the water vapor in our breath, right? All of that is subject primarily to osmotic force, right? Where the solutes go, the fluid follows, right? And it all has to do with the distribution of water molecules in two different connected compartments, right? The number of free water molecules has to be the same, and that's why osmosis takes place, right? The water will follow the solutes to increase the number of free water molecules compared to the number of free water molecules in the compartment that has fewer solutes. Okay. Net filtration involves capillary hydrostatic pressure, such as blood pressure, interstitial oncotic pressure, which pulls water back in to the blood. The forces that favor reabsorption are capillary oncotic pressure, which is water pulling pressure, and interstitial hydrostatic pressure. Okay, so the major forces that promote water movement out of capillaries are the capillary hydrostatic pressure. The major forces that control water movement back into the blood is the plasma oncotic pressure. So one of the main components of plasma oncotic pressure is albumin, which is made by the liver, okay? The liver makes plasma proteins as one of its many jobs, and if you lack albumin, you're going to lack oncotic pressure, and you're going to leak fluid into other compartments, okay? In starvation scenarios, such as in kwashiorkor, you'll see individuals with distended bellies. And the reason for this is that they're losing fluid volume to the abdominal pelvic cavity through the blood vessels in the peritoneum. Okay. And that's the result of their diet not having enough protein in it, because you eat protein to make protein. And so if you don't have a protein source, it's hard for you to produce sufficient protein. Okay. You'll also see this in people that have cirrhosis of the liver in the later stages. Because of the damage to the liver cells, not enough albumin is being produced, and you'll see the classic distended abdomen. Okay. Edema is just an accumulation of fluid within interstitial spaces, causes an increase in capillary hydrostatic pressure, a decrease in plasma oncotic pressure, an increase in capillary permeability, and lymph obstruction, as in lymphedema. Okay, it can be localized or generalized. Okay, so let's go through examples of each of these. Right, an increase in capillary hydrostatic pressure. A classic place you might see this is in obesity and pregnancy, because the venous return to the heart is impeded as a result of the longer blood vessels producing resistance in the system. And of course, the main forces that push blood back to the heart are the skeletal muscle pump and the thoracic pump. The fact that you breathe and you move squeezes blood through these one-way valves and eventually adds to the venous return. Well, what will happen in individuals that are heavy is that it's tougher to do that. And the blood will pool in the lower extremities, in the areas below the heart, and you'll get fluid accumulation. Okay, and so you'll see swelling in the wrists and ankles, for instance. Okay, a decrease in plasma oncotic pressure, we just discussed that with cirrhosis and in starvation. Okay, an increase in capillary permeability, now that's a different deal. That can be the result of excessive production of histamine. All right, the histamine is an inflammatory mediator. It initiates inflammation, and it makes the capillaries more permeable. All right, so what happens in inflammation is you see swelling. All right, and that's the result of the action of histamine. When it gets to an extreme point, okay, what you'll see is that all of the capillary beds open at the same time. And if they all open at the same time, your blood pressure will drop to the point where you could pass out and die. And that's called anaphylactic shock. Okay, that can happen as a result of a bloodborne infection like in septicemia, or it can happen as a result of an allergic response. Okay, and so that would be generalized edema. Okay, all right. So here you can see the interplay of the things that produce and mediate edema. Okay, the permeability, the oncotic pressure, lymph obstruction. Okay, this is one that we should address. In individuals that have to have lymph nodes removed because they've become cancerous, remember that lymph nodes will harbor cancer cells in some cases, and in some cases the cancer will take over the lymph node. And because we don't want it to spread, we surgically remove the lymph nodes and we lose that drainage. And that's about 15% of the fluid at every capillary bed. Okay, and you might think 15% is not much, but if 15% is left behind 24/7, 365, then you're going to have massive edema. Okay, and that's exactly what happens in people with obstructive lymph drainage. That's why we tell them to wear pressure garments, and we try to control total body water. Okay, another spectacular example of this is in the condition known as elephantiasis, in which helminths spread by mosquito bites get into the lymphatic capillaries and block them. And when they're blocked, the fluid accumulation is dramatic, and the area swells up quite extensively. Okay, it's sometimes called elephantiasis because it causes the lower extremities to look like those of an elephant. Okay, they get so thickened and edematous. Okay, in the inguinal lymph nodes, if this happens in men, this can cause scrotal swelling to the point where the scrotal sac has to be carried around in a wheelbarrow. Okay, a lot of the areas where this is an endemic disease are third world countries that have poor control of the mosquito, and as a result, they often lack medical treatment, so they just have to live with the disease. Okay. Sodium and chloride balance, right? Sodium is the primary extracellular fluid cation. Regulates osmotic force, and as a result, regulates where water goes. It has a role in membrane potential, in acid-base balance, and cellular chemical reactions and membrane transport. Okay, so remember that it's sodium and potassium that are the main players in establishing membrane potential. Okay, the membrane is 20 times more leaky to potassium than it is to sodium, and that's why sodium tends to accumulate outside the cell. Okay, and this is also why sodium imbalances are not quite as serious as potassium imbalances. If a potassium imbalance occurs, the increased permeability in the membrane means that the effect on the cell will be more keenly felt. Okay, chloride is a primary extracellular fluid anion and provides electroneutrality. It basically follows the sodium. The sodium has a positive charge. The chloride has a negative charge. Okay. The renin-angiotensin-aldosterone system is one of the long-term mechanisms for fluid balance. Okay. Yes.
Can everybody mute their phones? Because somebody's it say Whitney Bailey. It keeps on flashing. I can hear the background noise.
Let me mute it. Let me mute.
You're in the lobby.
I know.
Okay.
Let me mute everybody.
Thank you.
Yeah. That's all right. Yes. Okay. It looks like everybody's muted. It's my location that's producing a lot of back.
Renin-angiotensin-aldosterone system. The renin-angiotensin-aldosterone system is a classic endocrine system that helps to regulate long-term blood pressure and extracellular volume in the body. The system begins with the release of angiotensinogen into circulation by the liver. This may be in response to low blood pressure and adverse changes in sodium concentrations. An enzyme, renin, is secreted which cleaves angiotensinogen to form the inactive decapeptide angiotensin 1. Further transformation of angiotensin is carried out by angiotensin-converting enzyme, or ACE. This is predominantly found in the pulmonary circulation. However, ACE is also produced in the vascular endothelium of many tissues, including the kidney, adrenal gland, brain, and heart. The angiotensin-converting enzyme converts the inactive precursor angiotensin 1 into the vasoactive peptide angiotensin 2. In addition, alternative pathways exist that do not rely on either renin or ACE. In non-renin pathways, enzymes like tonin and cathepsin D release angiotensin 1 from angiotensinogen and tissue plasminogen activator, or TPA, and can make angiotensin 2 directly from angiotensinogen. This bypasses the midway production of angiotensin 1. Enzymes like chymase can form angiotensin 2 from angiotensin 1 via an ACE-independent pathway. Angiotensin-converting enzyme also degrades bradykinin, which is required for synthesis of a major vasodilator, nitric oxide. Angiotensin 2 binds AT1 receptors expressed on the surface of vascular endothelium and impairs nitric oxide synthesis as well. Reduced bioavailability of nitric oxide combined with the stimulation of AT1 receptors on smooth muscle cells causes vasoconstriction. In addition to a vasoconstriction effect, stimulation of AT1 receptor causes the adrenal glands to release the hormone aldosterone, resulting in sodium retention. Combined with vasoconstriction, this increases blood pressure. In the final stages of RAS, the kidney reduces the production of renin. Most of the known actions of angiotensin 2 are mediated through the AT1 receptors, which can be found in the kidney, heart, vascular smooth muscle cells, brain, adrenal glands, platelets, adipocytes, and the placenta. Angiotensin 2 type 2 receptors can be found in low levels mainly in the uterus, adrenal, central nervous system, heart, and kidney. AT2 receptors appear to counteract the effects of AT1 receptor stimulation. Another angiotensin II type receptor is the AT4 receptor. Its stimulation may increase synthesis of the natural inhibitor of TPA called PI1, thereby reducing effective fibrinolysis. Stimulation of AT4 receptor appears also to promote cell growth and proliferation.
So that's the point, okay, is to bring the blood pressure back up. Okay, it's a long-term adjustment. Okay, water balance is controlled by aldosterone and ADH, among others. ADH increases fluid retention at the kidneys, and it stands for antidiuretic hormone. It's made by the posterior pituitary. It's actually manufactured in the brain. Okay, thirst perception as a result of osmolality receptors. Hyperosmolality and plasma volume depletion trigger their firing and trigger thirst. Volume receptors are also present, as are baroreceptors. So, an example of how this works, right? The stretch of the atria is one of the things that responds to stretch receptors that trigger the release of atrionatriuretic peptide, and that causes your kidneys to secrete more sodium, and the water follows the sodium out of the body, and that reduces your blood pressure. Okay, so this is a hormone that acts opposite the way aldosterone works, right? Aldosterone is your sodium retaining hormone, and it's made by the adrenal cortex, and it causes your body to hold on to more sodium, which makes you hold on to more water as a secondary mechanism. Okay, so there is how it's all hooked up, right? The hypothalamus is in control of the posterior pituitary, right? And also has hormones that can control the adrenal cortex. And as a result, ADH and aldosterone are part of this renin-angiotensin-aldosterone system, okay? Controlling total volume, okay? Isotonic alterations are where total body water changes with proportional electrolyte and water change and no change in concentration. Okay? You have both isotonic fluid loss and isotonic fluid excess. Isotonic fluid excess can lead to edema. Isotonic fluid loss can lead to dehydration, okay? Just because of changes in volume. We're talking isotonic, we're talking the physiological solute concentration that's present in the tissue fluid, which means that cells in an isotonic environment don't lose or gain water at unequal rates, okay? So they're able to maintain their shape and perform their function, okay? What would be an example of an isotonic fluid loss? A stab wound, okay? And you bleed, okay? Isotonic fluid excess, you could see that if you were consuming excess isotonic fluid and your kidneys weren't working the way that they should, okay? And that could result in edema, okay? Hypertonic alterations include hypernatremia, a serum sodium greater than 145 milliequivalents per liter. It's related to sodium gain or water loss. Water movement from the ICF to the ECF results, okay? And so you see intracellular dehydration. So those cells will crenate, they'll shrivel up. Manifestations are thirst, weight gain, bounding pulse, increased blood pressure, okay? Why? Because you're pulling in more fluid, all right? Central nervous system will see muscle twitching and hyperreflexia, confusion, coma, convulsions, and cerebral hemorrhage. Why? Because you're changing the membrane potential, okay? And as a result, you get this hyperresponsiveness, okay? Hypertonic alterations include hyperchloremia, okay? This occurs with hypernatremia or a bicarbonate deficit because bicarbonate and fluoride are often interchanged for each other when the cell tries to maintain electrical neutrality, okay? Hypotonic alterations decrease osmolality Hyponatremia or free water excess decreases the extracellular fluid osmotic pressure, and water moves into the cell through osmosis, and the cells expand. Okay, so basically, what you're describing here with hyponatremia is water toxicity. Okay, if you take in more water than your kidneys can clear, all right, you're going to see tissue edema because the cells will swell up. The worst possible outcome of this is cerebral edema that can lead to coma and death. Okay, and there have been some stories in the news as recently as a year ago of a couple of people who have died as a result of drinking too much pure water too quickly. Okay, everything has a limit, and when you overload that system can't handle it, and the results produce disease, and in some cases death. Hyponatremia is a serum sodium level below 135. Sodium deficits cause plasma hypoosmolality and cellular swelling. Causes include pure sodium loss, low intake, and dilutional hyponatremia. Okay. Again, this is going to be often the result of endocrine problems. Okay. Aldosterone is your sodium retaining hormone. If you lack aldosterone production, you're going to lose sodium. Okay. And the result will be the hypoosmolality and the cellular swelling. Okay. What do you see? Most life-threatening includes cerebral edema and increased intracranial pressure, like we talked about with water toxicity. Lethargy, confusion, decreased reflexes, seizures, and coma. If it can lead to loss of extracellular fluid and hypovolemia, okay, you can see hypotension, tachycardia, and decreased urine output. Okay. If it's dilutional from too much water, you're going to see weight gain, edema, ascites, which is that distended abdomen, and jugular vein distension. Okay. Water excess can come from compulsive water drinking or decreased urine formation, so problems with the kidney. All right. Syndrome of inappropriate ADH secretion is another possibility. Okay, if you produce too much antidiuretic hormone, you're going to hold on to too much water, and the result will be hyponatremia with hypervolemia. Okay, so you're going to have both conditions happening at the same time. Okay, your blood pressure will go way up as a result. Okay? Water excess, cerebral edema with confusion and convulsion, weakness, muscle twitching, nausea, headache, and weight gain, okay, primarily from the fluid retention. So not a surprise there. Hypochloremia, usually the result of hyponatremia and elevated bicarbonate concentration, develops as a result of vomiting and the loss of hydrochloric acid. It occurs in CF, and the treatment of the underlying cause is what you need to deal with. Okay. All right. Let's pause here. Let's take 20 minutes, and I'll change my location so that we don't have all the background noise. And
Hey, Richard.
Zoom. Okay. All right.
Hey, Richard. Ebony, I'm
Yes,
sorry.
question?
I have two questions. So, are these just the PowerPoints, what you're reading from, like they're already on Canvas and we can follow along via the PowerPoint?
Yeah,
or
they're posted. They're posted. Mm-hmm.
Okay, is there a specific book for your class that maybe we should get? Because, like, in the past, there'd be books that we buy that we don't use.
It's in the syllabus. These are from the book. I can. It should be where the syllabus is posted under syllabus. It should give you the title of the book and the ISBN. Okay.
Yeah, I understand. I'm saying because it's been in the past. I've graduated through LPN from here, and we've bought books that cost that we never used through the school year. So I'm asking.
Oh no, I'm definitely using this book because your test questions can be pulled from the test banks from this book.
Okay.
Which is why I want you to read the book. Yeah, for sure.
All right.
No, I don't play that. I don't play that at all. Okay. So let me.
Excuse me.
Yes.
Can you try to send me the invite, please?
Oh, the invite. Okay. Send me your email. So
I did send you. I even sent you an email since yesterday.
Yeah. Okay. I will do that. All right.
Okay.
And I will join you guys.
Richard, me too. I emailed you several times to send me
Okay.
the invite.
Okay, which email did you send it to?
Yeah,
CNC?
I've sent you a direct message with my email on it.
Okay, I will track that down. Okay,
Thank
so
you.
let's go 20 minutes and then we'll relocate.
Ever wonder how could they even better? Let me let you in on a lucky little secret. It's normative. Just one normative. And we just ready and excited for whatever the day throws at me. Window shopping? More like treasure hunting. With normative in my system, I'm not just walking, I'm exploring. Stress? What stress? It's amazing how the little things in life shine brighter when your mind is clear. That's the normative difference. It's not about changing the world. It's about changing how you see it. So if you're looking to elevate your day, make every moment count with normative. It's about making the most of every moment, feeling great, and truly living your best life. Ever wonder? Got my Tito's homeboy. Got my Kool-Aid. Oh boy, I got my Kool-Aid.
Can you please mute?
The other day, pre-order classics.
You come on.